welcome back to this to the afternoon session. We will talk about ethics, and that was one of the important topics I wanted to address again. Medicus Mundi Switzerland did a mapping exercise, and the report can be found in the resource section on our website. One of the issues which came up several times in the interviews which we conducted was the topic of ethics and how ethics can be applied, how can we use digital health technologies ethically. And during my research, I came across Cansu, and she is the founder and director of the AI Ethics Labs and was listed among the 30 influential women advancing AI in Boston and 100 brilliant women in AI ethics. So it's a great pleasure having you here, and I was so impressed by your talks, which I found on YouTube. You gave a TED talk, and then I thought, okay, I want to invite you to the Medicus Mundi conference so that we can listen to you and learn from you.
So, Karin, don't worry about the name. I know it's a hard one. So it is Cansu Canca, and it's a Turkish name, and it's a tricky name. So I know. Don't worry about it.
I'm really sorry for that.
That's totally fine. Don't worry. So I will speak about how we think about ethics when designing and using technologies, health technologies. So let me start with, to keep with the, so to speak, spirit of the time, I am going to start with some COVID-related cases and start from the non-digital ethical questions and move towards the digital ethical questions to make it, to show how we transition in the ethics discussion. So the first case that I wanted to talk about was with the COVID-19, we faced obviously a lot of ethical questions in public health, and one of them was allocation of scarce life-saving resources. Not a brand new problem, it's always there, but this was again a new way of having to face and having to make decisions about it. So the allocation of ventilators and ICU beds were one of the major conversations of ethical concern. The basic question is this: who should be given priority? Should we give priority to the sickest because they need the ventilation or the intervention most urgently and most? Should we give priority to those who are most likely to benefit from the intervention? That sounds more outcome oriented. That is more outcome oriented, which makes a lot of sense. But of course, that would actually eliminate some of the sickest people. Or should we just do first come, first serve, which sounds fair. On the other hand, of course, we know that those who come to the hospitals first are usually those with better means, better socioeconomic backgrounds where they can utilize the healthcare system more effectively. So this was one major conversation topic in terms of ethics during COVID-19. And it seems like it's gonna come up again as the second wave hits countries. And then the second conversation, which is again becoming a live conversation, is the lockdown measures. When should countries implement lockdown measures, and for how long? And here again, we are sort of looking at how to compare different types of harm to different groups. If we just look at the vulnerable groups, then we have to define what is a vulnerable group. If it is physically vulnerable groups in terms of being affected from COVID, then lockdown seems like an immediate and useful measure. On the other hand, for socioeconomically vulnerable groups, that might be very problematic, because if they don't have savings, and if they cannot keep earning money because of the lockdown, and if the country doesn't have good social security system, then this poses a huge risk for their living circumstances, for their well-being beyond COVID and apart from COVID-19. Then, of course, we have these other questions. What about the essential workers? How does the lockdown measures or lifting the lockdown affect the essential workers and the youth who are less of a risk group in terms of getting COVID? Well, getting very sick from COVID, but who are losing their normal education time and their normal social interactions during the lockdown. So, I mean, both of these conversations, of course, are very detailed, and if we wanted to discuss them, we would have to dive much deeper into these bumper sticker style introductions that I'm giving to them, which is going to be the case for most of the cases that I'm going to show, because I just want to give sort of like an overview of what type of ethical questions we are discussing, and I hope I will have time to take your questions to go deeper in some of these if you have questions on these. And as Karine mentioned, a major discussion revolved around the contact tracing. And why did we have such a lively conversation, so to speak, about contact tracing? Well, because COVID-19 posed a particular challenge to the traditional contact tracing methods because of its specifics. Its route of transmission is respiratory, which means that unlike, for example, sexually transmitted diseases, you have to remember a whole, like your daily routine. You have to remember who you have spoken to, not just who you have been intimate with, so to speak. It has a up to 14-day incubation period during which you can be contagious and during which you can be asymptomatic and contagious, which again makes it much harder to detect and remember when your test result comes positive, to remember what you have done in the last 14 days when you were feeling perfectly normal, so there was nothing worthwhile to remember. And of course, the rapid rise in the cases made the contact tracing, manual contact tracing, very difficult, because manual contact tracing is laborsome. So it takes a lot of time and human resources to do it accurately and effectively. And this raises ethical questions. So if we have to use the manual contact tracing, we have to understand, well, we cannot reduce the harm. Well, we can, but it is not very efficient. It is not as efficient in reducing the harm as it is, let's say, doing the contact tracing for HIV. In terms of access to information of those who have been exposed to the virus, well, the problem is that if you are not informed, if you cannot do this fast, then you cannot let the people know that they have been exposed, which means they cannot take actions to protect their community and their loved ones. And this could be potentially counteracted to a certain degree if we override patient privacy. So if the names of the positive cases are publicly available, then everyone can self-identify. But of course, there's a huge problem with this, which is the patient privacy, which we definitely don't want to override without a very, very good reason. So the question is how to balance these different and very important and very demanding ethical concerns. One answer came from the digital contact tracing idea. So the digital contact tracing basically starts off with the privacy by design structure, which means that we can protect patient privacy. So I should probably say something about how the digital contact tracing works, which is, I'm sure most of you know, but still just a quick recap. Through the Bluetooth system in the phones, in the smartphones, the application communicates with the other phones and records only the encounters that are close contact. So it is for more than 15 minutes and within the 2 meters distance. So it exchanges these randomly generated IDs just to keep a log on within your device. So it's not shared with anywhere, with any central server or anything. And if one is tested positive, then one can trigger the information of sending their randomly generated numbers to a server, so that the other phones can check and see if they have been in close contact with them. So the system that was designed, so especially the DP3T protocol, adopted initially from UK, but adopted most within Europe, is a privacy by design system. So it protects patient privacy, but it also protects the privacy of those who have been exposed to the system, exposed to a positive case. Using such a digital contact tracing would make the information available very quickly to those who are exposed. So the access to information problem is also solved there. And if it is accurate, that's an important question to address. Of course, if it is accurate, here we have to benchmark it against manual contact tracing. If it is accurate as much as manual contact tracing or more, and if it is fast, which is a given, it will be fast, it can drastically reduce the harm. Usually the conversation about digital contact tracing goes towards, well, but it's not a silver bullet, or it didn't turn out to be a silver bullet. Well, contact tracing itself is not meant to be a silver bullet. It is just one of the mechanisms to control epidemics. So therefore, digital contact tracing, of course, is not going to be a silver bullet either. It's just going to be one of the useful methodologies, which would also be very effective in better allocation of testing or isolation. So it will feed into the other control mechanisms. Now, it looks like we solved the question of how to balance these ethical issues through a design, through a technological design. But now, as most of you are aware of how this digital contact tracing story has unfolded so far, we faced another problem.
Stop. Just a second. We can't hear you. Yeah.
When did you not start not hearing me? I don't know what happened.
35 seconds.
Okay, good. So, thank you, Karina. So it looks like we got rid of the how to balance these ethical questions through a design. But now we face another problem, which is how we are gonna make the digital contact tracing effectively implemented. And as most of you know, we face throughout the world, we face a big problem here because none of the countries have enough rate of download of the applications. And first one is, of course, downloading the app. The other one is keeping it running. And all of the countries so far have been falling short of coverage that would make the digital contact tracing effective. And the other question is about the response. If you get a positive test result, can we reliably assume that you put it in the app? And if you get an exposure notification, can we reliably assume that you are gonna do as suggested? So self-isolation if suggested, or testing if suggested. We don't seem to get this reliability going either. So here, now we have the tool seems to be there, although its effectiveness requires more testing. But in order to do that testing, we still have to implement it, but we are unable to implement it. And that brings us to another ethical question, which is about both policy and design. How should we implement these systems? Should they be voluntary or should they be mandatory? If they are mandatory, how can we make them mandatory? How can we enforce them, since they are privacy by design? We cannot know who is using it and who is not using it. And for that, can we have design solutions? By the way, I have these links underneath, and I'll post them after the talk to the chat. So there are papers that I have written or the lab has produced about these issues that if you are interested, you can look further. So from this public health question, I want to move to another ethics type question, which is about biases in health prediction tools. So this is an article that came out last year, and it is a really good article. It's a short article, so I highly recommend it. It is about the prediction algorithms to identify and help patients with complex health needs. And when these algorithms are tested closely and looked closely, it turns out that they are using, since you cannot use illness as a variable, you need a proxy for illness. So they are using healthcare costs as a proxy. But because black patients and white patients have unequal access to healthcare, the society spends less on Black patients, which means that their illnesses are underreported. So remedying this disparity increases the percentage of Black patients receiving additional help from 17.7% to 46.5%. So we are talking about an algorithm that is used widely around the US to basically deal with this complex issue of whom to prioritize, which is a very complex question. So we need an algorithm that helps us with this. But it turns out that it is using a proxy that is systematically disadvantaging a certain group within the society. We at the AI Ethics Lab, recently we did a webinar on this for the company called Applause. And there, what we have talked about is the types of biases that goes into AI systems and how can we deal with them. So just very briefly, the bias can come from your data set if it does not represent the world. So if it does not have, let's say, enough dark faces, your facial recognition tool is not going to be very good in recognizing dark faces. Or it can come from representing the world really well, including all of the discrimination. So in this case, it represents the world together with its discrimination, which is that the Black patients just don't have such access, and it is being replicated. This discrimination is being replicated and amplified through this application, through this algorithm. Sorry. And there are ways of course, looking at these AI systems and making sure that they are less biased. And keep in mind, by the way, this is not just relevant for those who are developing these systems, but if you are a healthcare professional who is using these systems, you might need to ask whether these tests are being done, whether they've been checked for biases and what type of biases. So this is an important thing for anyone in the using and building group. And finally, this is my last example. Another area that, so basically one thing that I want to say is that throughout the whole health world, we have digitalization introduces new ethical problems in addition to the existing ethical problems within ethics and health. So with human subject research, which has the most developed ethics framework around it, now we have the AI research with human subjects. And traditionally, we look at the principles of biomedical ethics, respect for persons' autonomy, do good and minimize harm, and be fair. However, when we look at the common ethical questions in AI human subject research, we realize that they are not very guiding. So what do you do with algorithmic bias, for example? How do you address this? What should be the requirements to address this? What tests should be mandatory to do? What is the responsible way of checking for biases? What about the secondary use of algorithms? If you are building on top of another model, should you go back to its data set? Is that a requirement that you should have, or also would that be feasible? We have a major question about re-identification, because with the personal data now, by associating different large data sets, it's very, very possible to re-identify people. So the de-identification and anonymization is becoming more and more something that is just impossible. And one way, of course, to get around this is to do federated learning within the devices, or do other privacy by design structures, put in place other privacy by design structures. So I'm not going to go through all of these, but just to show that the AI research is posing a lot of questions that our traditional research ethics framework is unable to answer. And we have created modules and did a webinar for this for City program, which you can check as well. So when we talk about AI ethics, basically we are talking about three main areas: developing ethical technologies, ensuring ethical processes. So this is where the research, for example, becomes very important, and using and implementing tech ethically, which means that not just those who are developing these systems, but those who are using it also have a responsibility. And we do this through design, but also through rules, in the sense that putting in place safeguards. And keep in mind, realize that this structure requires going far beyond code of conduct or simple guidelines, or even the human rights framework, which I can talk more later. So currently our system is we, in research ethics, we look at the research protocol and do an ethics review and ethics approval, but then the design, development, implementation, and updating is not engaged with ethics at all. That needs to be changed. And with a goal of changing this, many countries around the world and companies, organizations have published their AI principles. So this is from our toolbox 2015. You have like 4 documents. 2020, we have over 100 sets of principles. However, they can just be summed up under the 4 principles of biomedical ethics, which I mentioned earlier. And this is the EU's trustworthy AI guideline, and they argue as well that all of these principles are really can be categorized within those 4 principles. And the explicability they add as an enabling principle. So in order to make this more operational and actually make it usable, we turned it into a little tool and show how these instrumental principles, which are not valued for themselves. So transparency or consent is not goals in themselves, but they serve to uphold justice, to respect autonomy. So we put this tool to both show this relationship between the principles and also make sure that you have a tool to look through when you are evaluating a project or a product. And there's an article that I wrote that's coming up on the ACM, communications of ACM. Again, link is here. So this is our toolbox. And the final point is, in order to put ethics, run alongside with all these different stages of innovation, we need way more than ethics review. We need to put aside ethics as compliance, ethics as policing, and go really as ethics for problem solving and puzzle solving, because ethics really is about when you don't know what is the right thing to do, figuring it out and implementing it. So what we do is we create ethics roadmaps, ethics analysis of projects and products for the companies, organizations, strategies, and training, which is of course extremely important. We call our model the PI model, puzzle solving in ethics, and it should be done within companies, incubators, research institutions, and governmental organizations. And those who are responsible are basically everyone who are involved in implementing and using the AI systems. Again, you can learn more about it on these pages, which I will put in the chat in a bit, and that's our lab's website. And that's all. Thank you.
Thank you so much, Cansu, for this wonderful presentation and breaking down a bit this complex topic of ethics and how to apply it. I think we open the floor and invite the audience to ask 1 or 2 questions. Okay. There is Juan is saying, thank you for presenting the ethical topic in such an easy improvement. Very much appreciated. What about the access to technology biases, particularly true for low middle income settings? Similar, what about informatics literacy bias? Particularly true for the same settings, but also for elderly people in high income settings.
So I think when we say bias, we need to be careful about how we are really using it. So in terms of algorithmic bias, that means how these discriminations go into the decision-making of an AI system. I think Juan is not asking that specifically. It's more like the imbalance, how do you say it, like the unfairness of use of technology and availability of the access to technology systems. Equity principles, he said, yes, okay. And here I think the important thing is the technology systems should make sure that the vulnerable groups or lower socioeconomic backgrounds are not left behind. But here we need to be careful of what this means. So for example, just as an example, digital contact tracing is a good example here because a justice question is being raised. Not everyone has a smartphone. One answer to this is very technical answer, which is we can give cheap tokens to pretty much everyone who doesn't have a smartphone, and that will run the contact tracing app. So this is not like a lockdown is so much more expensive than just giving everyone a cheap token. So this is like a technical answer, technology answer. The other answer is even if those individuals who don't have a smartphone cannot use the contact tracing applications, if we can just reduce the infection within the society, that is going to be hugely beneficial for the vulnerable population, which is most susceptible to the infection. So just by making sure that the rest of us are behaving correctly, we can actually protect the vulnerable ones. This is not ideal. Like, the ideal is doing that together with the tokens so that we have the lower socioeconomic groups covered as well. And I think this type of mentality should be how we are thinking. What is the effect? Plus, how can we make this even more effective for the vulnerable groups in terms of technology?
Thank you. And another question from Lucy. Ethical values vary according to the culture. How do you account for that in your framework?
So, first of all, I don't have a framework in the sense that I'm a philosopher. So, and I would always argue that if you are going to use principles, if you have a hard question, your principles will conflict. And when your principles conflict, there's no other way but to go back to theories. You will have to deal with moral and political theories. This is how you reason. There's no way out of that. So I don't have a framework because I don't think that a framework actually answers complex ethical questions, including the questions about allocation of scarce resources, for example. But to answer this longer question of how would a framework deal with the cultural aspects, when you look at I'm Turkish. I have been working in Europe, in US. I've studied and worked in Asia. I've studied Asian philosophy as well. So I would say generally what you see is that the variables, how much people care about certain values differ, but the overall structure don't differ so much. So autonomy is always important in all cultures, but in the East, you can say that, well, a person's autonomy includes talking to his or her family and making decisions collectively, but eventually that's going to be her decision. So we have to understand this, and we have to put this in the, let's say, decision-making structure of the theory, but the theories don't really change that much. And I can say this comfortably as a moral philosopher.
Thank you. Let's take one more question before I hand over to Martin. So Anya says, thanks a lot for the talk. Did you draw any lessons learned from the Ebola crisis in 2014 for your work regarding contact tracing, access and ethical issues? Or was that still before the AI times for issues like contact tracing?
Yeah, so I think there are two things about the Ebola crisis that's quite different from the COVID. One is that, yes, it was sort of before the digital technologies became as capable. And the other thing is it's still easier to trace Ebola because of the incubation period and the localization of the outbreak. So it did not become a global pandemic. And the way it presents, the illness presents itself. COVID is particularly difficult for contact tracing, exactly for the same reasons why it's particularly difficult to stop it from becoming a pandemic, global pandemic, because it's mild enough that you don't even realize you might be passing it around, but it is also contagious enough that it actually does infect people. I will try to answer, I'm not going anywhere, so I'm just going to try to answer the questions on the chat. And if you have, I'll post all the links on the chat. And if you have more questions, just email me, follow up on that.
Thank you so much. That was really, really great, your inputs you just gave. Thank you so much. I hand over now to Martin, who will take over and will moderate the panel discussion. And I will say goodbye because that was my last moderation for today. Thanks so much for taking part. Stay on, and I hope to see you next year in person.